Welcome back, everyone, and we're going to move on now and talk about hepatobiliary cancers, HCC, and pancreatic cancers. And a lot of times we don't have too much to say about pancreatic cancer, but actually it's a couple of kind of interesting and very practical issues we're going to talk about today with Dr. Borad and El-Khoueiry. And as we've doing for all our modules, we'll start out with Dr. Divers.
Welcome back from the break. Thanks, Neil. I was just going to, a couple of pearls from the previous talk. Intriguing questions. Obviously, the Pelican graph was amazing, and you look at 90 months and hazard ratio of 0.07. We'd love to see that in these disease states. So we're setting the bar high for you guys.
Right.
All right? You know, when we think about the adjuvant setting and does it matter, PD-1 versus PD-L1 in the renal cell patients, you know, that's a debate for another time. But in the clinic, in the community, in this network, we struggle with the decision about it, you know, Ipi-Nivo versus those doublets and thinking about, you know, the durability of response and 20% progression versus that 95% clinical benefit rate that you see, you know, with the combination. And so, you know, we also think about managing side effects, and that's perhaps a data project that Krish and Mark and Miba could help with, like, you know, because we've got, you know, medical compliance data with their medicines. Let's see what the dosing is. Let's see how patients stay on therapy and going forwards. We were actually, last weekend, I was at a meeting and they had cardio-oncology as a new, you know, and so gave great guidance to the community on how to help manage this and keep people on therapy. So it's something we might want to look at in the future. But
we need ophthalmo-oncology.
Yeah, right, particularly in this setting. And then, you know, another, you know, amazing data on the enfortumab pembro and then the Nivo-Cis, you know, as first-line therapy in the bladder setting. So it'd be a great call-out project. If you think about like what our network chooses, how that's implemented going forward, some data that we can look at. So moving on to the hepatobiliary and pancreas cancers. Again, these are data pulled by Miba for patients throughout our network, and you'll see you know, about 700 hepatocellular carcinomas, about a little over 1,000 pancreatic cancer patients. You'll see the survival, the yellow bar here is a lot bigger in these settings than it was in some of the others. So we still have a lot of work left to do here. We like to look at next generation sequencing biomarkers to make sure we're choosing the right therapy for the right patient at the right time. And obviously, you know, looking at HRD and PARP use in pancreatic cancers is going to be intriguing. We see significant olaparib use. And with respect to the hepatocellular carcinoma with the patients in the network, you know, I think next time we probably need to look at stratification by Chiles-Pugh here really to help see what's going on when you look at this data. But a lot of Tisobev use and the Durvalumab use. For the cholangio patients, I think you see pretty wide adoption throughout the community based on that trial, you know, in combination with Cisgem and Durvalumab. So obviously this was a disease state where there was a need and the uptake was huge. Thank you, guys.
Thanks a lot, Fred. Yeah, that really is interesting how quickly when we see something positive like that, which is, I can't remember, was that a year ago or 2 years ago when that data first started coming out? And it was the last couple of years. In any event, we're going to talk about it now, and it is coming into practice. So, Mitesh, we asked you to talk about biliary tract cancer and pancreatic phase 3, a positive phase 3 trial in pancreatic. Haven't seen that lately, but a lot of clinical implications. Let's talk about it.
Okay, well, thank you, everyone, and pleasure to be here with this esteemed group. And as Dr. Love mentioned, years ago there wouldn't be a whole lot to talk about in these two tumor groups, and there's now every meeting there's something to report. So as was just highlighted, the adoption is very rapid with positive studies. So this is the TOPAZ-1 study, which looked at the addition of Durvalumab, PD-L1 antibody to gemcitabine and cisplatin, which was the standard of care previously. So flat dose Durvalumab, 1,500 milligrams on just day one of a 3-week regimen. And this was a 680-odd patient trial with overall survival as the primary endpoint and other safety and efficacy endpoints shown here. So key outcomes, you get some modest median survival benefit, but that's not the the real message here. PFS is also improved from a statistical standpoint. Response rate was also higher. From a safety perspective, from patients you must have already treated, you must have noted typically no significant adverse event rate being increased, but do watch out for elevated liver enzymes and biliary inflammation, because wherever the tumor is where you'll get the collateral immune response. Rapid time to response, and the duration of response is, respectable 6 months. If you look at the curves, the key message, as I said, is not the median survival, but the tails, like any immunotherapies. And now you get 1, 2, and even 3-year survivors. And those 2 and 3-year survivors ultimately will level off at around 10 to 12%. So even at 2 years, you see a doubling of the 2-year survival. We also have your tried and trusted pembrolizumab with Keynote 966. So this is another phase 3 study that was just reported earlier this year. And again, this was just adding on pembro on that day 1 flat dose that you're used to giving versus placebo. Overall survival was the primary endpoint, and the other efficacy and safety endpoints paralleled what I just showed you with Topaz 1. So again, about the same couple of month modest median survival difference. Not as much PFS difference here in this trial. Response rate was actually not different at all here. Safety is about the same when you look at overall perspective compared to GemCis, and you get responses that occur pretty rapidly. Again, the story is in the 1, 2-year landmarks and that tail, which is going to level off at about 10 to 15%. We can't tell who those patients would be right now, so it's very important to treat them up front, and it sounds like most people are already doing that, so kudos to you on that.
So it looks like we're facing a situation that it seems like it happens every day, where you have one standard involving an IO, and then another trial comes out with a different IO, and it looks pretty similar. Anthony, any thoughts about pembro as opposed to durva? The data look pretty similar.
These trials look quite similar, actually, despite the pembro trial allowing the continuation of gemcitabine with the pembro as maintenance. Not just the durva trial continued durva alone. Didn't seem to make a huge difference at cross-trial comparison.
Interesting. Mitesh, what about the issue? I think you alluded to the issue of hepatic toxicity from IOs, which you can see, but these people already have problems in their liver, and HCC patients. So really, same question. Is there a way to differentiate in a patient who's an IO toxicity from the IO versus some other cause, liver disease or tumor in the liver?
Yeah, that can be a little bit challenging. When in doubt, it's always best to assume that it might be immunotherapy toxicity, because you don't want to lose time if it was. So you give steroids. If it starts improving, you can look back and say it was immunotherapy-related toxicity, and obviously if it doesn't, it might have not been, right? So kind of trial and error approach.
Nothing about the clinical presentation, blood work, et cetera, the same thing?
The timing might help sometimes too. You might see sort of steeper rise without a bilirubin increase. That might be a tip-off. If you see the bilirubin also increase, it might just be a blockage.
All right, let's talk about targeted therapy. And I've been joking around that biliary tract cancer is the new non-small cell lung cancer, because all of a sudden you got all these targets.
That's right. So biliary tract cancers are the most target-rich GI cancers, and just like lung cancer, folks should universally be profiling these patients when possible, and earlier is better, because then you get the results back in hand instead of having to wait. So along those lines, FDA-approved agent, pemigatinib, FGFR2 fusions and rearrangements represent 10 to 12% of intrahepatic cholangiocarcinomas, so you have a decent yield when you profile. This is the trial that the approval was based on. It's an accelerated approval. So a little over 100 patients given 13.5 milligrams daily for 2 weeks and then a week off. Response rate is in the 30 to 40% range, PFS about 7 months. Rapid response, less than 3 months. Overall survival is a little less than 2 years, but this could also be prognostic, not necessarily fully response related. As was highlighted in the previous session, these agents have unique toxicities. Many of these are related to FGFR1 and 4. These agents are FGFR selective, not 2 selective yet. So those are hyperphosphatemia, dysgeusia, diarrhea, stomatitis. Then you have on-target toxicities like dry eye, nail changes, and alopecia, which are FGFR2 related. There's also retinal detachment, which can be severe. So anybody who goes on these agents, it's very important to get ophthalmology and dermatology engaged early if you can.
Retinal detachment, I haven't heard that one before. What's the mechanism?
In the eye, you have FGFR2 expressed normally in the retina and in the cornea. So when you give these agents, it's an on-target toxicity.
Huh.
Yeah.
Interesting.
So anything ranging from blurry vision to retinal detachment is the range of toxicities. Second agent approved in this space. There's a third that was approved but got pulled. That was infigratinib. So that's futibatinib. Again, trial, single arm, accelerated approval, a little over 100 patients. This is daily dosing, no breaks. You have a slightly higher response rate at 42%. PFS is also slightly higher, 9 months. And that's because this is a covalent inhibitor and overcomes some of the resistance mutations that you have with pemigatinib. So it's not surprising to see slightly better efficacy data. Same toxicities. The only issue here would be this is daily dosing, so you might have more chronicity of the toxicity compared to pemigatinib, where you have that built-in break. So I wish they had studied another schedule along with it, and I suspect that that's going to happen in the future.
You see responses in people who progressed on another one?
Yes. So besides the gatekeeper mutations, futibatinib should cover most of the other mutations that confer resistance to pemigatinib. So you could sequence futibatinib after pemigatinib, but not the other way around.
Because futibatinib is the only one that works after a prior.
Correct. You could sequence the other way around for toxicity, but not for efficacy.
Anthony, what about the issue of using these agents first line? For example, a patient who maybe you don't want to give chemo to older, frail patient. You know, this comes up in lung cancer. They don't even do randomized trials. They have a 40, 50% response rate with targeted therapy. They start using it first line. How about in this situation?
Yeah, so unfortunately, there's been attempts to study some agents like this in first line with chemotherapy. Those trials are very difficult to recruit.
How about without chemo?
Without chemo, I'm not aware of a trial looking at that without chemo currently.
The first line trials were without chemo. So pemigatinib has a trial without chemo that's phase 3, but it's a rare patient population, so it's taken a long time to recruit.
Right.
And what about tolerability? You alluded a little, Mitesh, to some of the issues that come up. Can you talk a little bit more about what you see in these patients and how you prevent and manage the issues that come up?
Yeah, so the most common things will be skin and nail changes. Patients' nails might get so brittle they might fall off. So this is something new with this class of agents, and that's why I said important to get a dermatologist involved early. And you want to follow them closely, so if they have very severe toxicities, you can dose reduce. Same thing with ocular issues. You don't want to wait till they have severe ocular events. You want to dose reduce or interrupt at the first signs of blurry vision, et cetera.
Anything in terms of preventing some of the nail change? I know this can be very disturbing to patients. Any way to prevent it? I hear different people trying different sort of non-medical approaches. Anything work?
Some of the things, oddly, that seem to have worked is just once the nails start having issues, just have them removed. That prevents the pain that might go with a splintered nail or it even getting infected. So
Interesting. Zanidatamab.
Yeah, so a new target, HER2, which, of course, breast cancer has laid the paradigm here. So zanidatamab is a bispecific antibody to HER2 and another domain where pertuzumab acts. So you can see in that upper panel there, light blue is the trastuzumab domain and the dark blue is the pertuzumab domain. So you don't have to give 2 drugs, it's built into one. This is a trial that was just reported at ASCO this year, 80-something patients, testing by immunohistochemistry, mostly 3+ and then some 2+s, given every 2 weeks, 20 mg per kg. From the waterfall plot, you could see 70 to 80% of patients have some tumor shrinkage. Response rate, very respectable, 40-something%. very fast responses, less than 2 months. Those who respond, over a year. And the toxicities would be what you would expect with trastuzumab and pertuzumab, diarrhea, and then in some patients you want to watch the ejection fraction like you would anyways with trastuzumab. So very promising agent, not available yet, but hopefully sometime next year could garner accelerated approval.
I just want to point out this is a bispecific, but this is a different type of bispecific than what we were talking about with lymphoma and what we're going to talk about with myeloma, the immune bispecifics that have CD3, an immune end on it. This is kind of, to me, kind of like amivantamab in lung, which both of the bi parts of it are targeting the receptor on the cancer. So it is a bispecific, but you don't see cytokine release and those kind of inflammatory issues.
It's basically like giving trastuzumab.
With the immune bispecific. So these are a lot more straightforward, I would think.
Yeah, exactly. It's like giving trastuzumab, pertuzumab, really. Okay. So other agents, tucatinib and trastuzumab, this was also reported at ASCO, now in JCO. Very high response rate. The duration of response is shorter, though, only 6 months. And you have to combine an oral agent and trastuzumab. So this is available now, perhaps off-label at this time. So could provide agents that you could give to your patients currently if you like.
And 46% response rate is pretty interesting. And of course, it's approved in metastatic colon right now. It looks like their activity in other, this looks, fairly active as well. Anthony, tucatinib, one of the issues with that we know from breast cancer has CNS penetration. Do you see more brain mets in people with HER2-positive biliary tract cancers?
That has not been really reported, unlike, I think, with colon and breast, where HER2 positivity may be
more
associated
patients,
with,
too.
Yeah. So it may be there. We just, because of the numbers, may have not picked it up yet, but we'll see.
Yeah. Folks haven't lived long enough yet with these agents, so
Yeah.
I think you'll start seeing it like breast cancer.
We had a question actually earlier when we were talking about IOs and biliary tract disease about whether the site makes a difference, whether it's intrahepatic, extrahepatic, biliary. Does it matter where it starts in terms of some of these data? Do you need to look at a trial just in cholangio? And same thing with HER2 and everything else. Do you lump them all together or you try to split it out? Anthony, I see you smiling. What's your answer?
Well, it's a tough area because we talk about it all the time. So for the IO agents, the subgroup analyses have shown a benefit in all subgroups, but the majority of the patients in both trials are intrahepatic, and seems that the benefit may be the most accentuated in that subgroup. FGFR2 is most common in intrahepatic. So what we're going to see is these alterations are different by site. HER2 is more likely in gallbladder, for example, in extrahepatic. So in that sense, the disease is already being fragmented that way based on the actionable mutations.
Of course, the more you fragment it, the less numbers. And here it is again, TDXD.
Okay, so could you give an antibody drug conjugate? And the Destiny-02 trial was highlighted, and you can see there were about 40 patients there with biliary tract cancer, very high response rate in the 3+, 60-something%. The issue with these agents will be the toxicity, cytopenias, and the dreaded interstitial lung disease, which could be fatal. You could see one event there. In another trial from Japan, you see similar numbers as well. Again, interstitial lung disease and cytopenias being the issue.
I'm kind of curious, have you used TDXD in any? I hear people in practice tell me about cases that respond. Have you actually done this outside of protocol setting?
Yeah, I have. And again, I try to use the other HER2 agents first because of the concern for toxicity, but if those don't work, this is the go-to drug.
Just kind of curious, always interesting to ask, and we're going to get into this in the breast session at the end of the day, Anthony. Of course, TDXD, started with breast cancer. Now we see it in lung cancer, GI cancers, et cetera. And of course, as Mitesh was talking about, the big issue there is interstitial lung disease. And the breast people are very aggressive. We're going to talk to them this afternoon, but they're very aggressive about imaging. Even the patient's asymptomatic. And then if they see something, they hold therapy, give steroids, will retreat. They don't retreat if the patient is symptomatic. you guys don't see anywhere near the volume of patients. How do you figure out what to do? What do you do?
It has to do with the survival of the two populations as well. The cholangio patients have much shorter survival. And usually you're using these agents in third line, I would say, and beyond. So I think we really go by not just imaging, but if the patient's starting to develop symptoms or hypoxia, if it's just imaging changes, we may push through still.
Yeah. I mean, we might see some of that here as well. You saw IHC 3+, the duration of response was 22 months. So there are advantages to being a general oncologist sometimes as opposed to an expert.
Well, actually, I was going to ask you, did they see responses in HER2 low?
It's very low. You can see in the Destiny trial, 0% in HER2 low. And in the Japanese trial, it was 12%. So it's not anything to write home.
It's going to be interesting to see whether these other cancers, upper GI cancers, I don't know how anybody's seen yet any definitive data about HER2 low and TDXD outside of breast.
Yeah.
But we'll see.
Okay.
Here we go.
All right, here's the
Pancreas.
positive study for pancreas cancer. So this was the Napoli 3 study, reported a few times. This is the most updated report, 770 patients. Gemcitabine nab-paclitaxel being the comparator here, and NALIRIFOX, so everybody's wanted a FOLFIRINOX study. So this is as close as you'll come. So liposomal irinotecan, 5-FU. I don't know why they use the leucovorin here because there's no bolus. And oxaliplatin, a lower dose than usual. Primary endpoint was overall survival. So here's the key numbers. Couple of month benefit with overall survival on a median basis. PFS response rate parallel this. There's higher GI toxicity with the triplet. There's actually higher myelosuppression with the doublet. And that's because some of the bolus wasn't there and the oxali is lower. And of course, the other parameters parallel the overall survival benefit. So now the question has been answered. Which regimen do you pick if you have both and you can use the triplet regimen if possible, I guess. So as I mentioned with the AEs, higher GI toxicities with the triplet, higher myelosuppression with the doublet.
So before you go on, I got to ask you both what this means. Because one of the things about this trial, this is not the kind of trial incidentally you put your patient on because they're going to do better. You're going to put them on because they're going to understand for future patients, and it's so helpful to have this practical information. So we actually did a survey. I think you two were actually in it, but a couple months ago about these data. Here are some of the questions we asked. I'd like to kind of come back to this again. Okay, so first of all, is a triplet like NALIRIFOX or FOLFIRINOX somewhat more effective than Gem-Nab, Anthony?
I would say yes.
And Mitesh, again, these are the questions we asked the whole group.
Yeah, I would agree.
Agree? Okay, so come back to you, Mitesh. Efficacy of NALIRIFOX versus FOLFIRINOX.
I would say they're probably comparable. People will argue that, well, this was the regimen in the study, but the numbers are pretty similar to what were in PRODIGE, so I couldn't fault anybody for using FOLFIRINOX.
So, yeah, and again, that was the same answer we got. Also, one of the things that was pointed out to me, too, you mentioned it briefly, was that Gem-Nab was not maybe as much a walk in the park as people thought it was. There was a lot of neutropenia and, not that necessarily easy. I'm kind of curious for older, frail patients. In the past, Anthony, people thought about Gem-Nab a lot, but what about NALIRIFOX? Do you think it's more poorly tolerated? There was less oxali also.
Correct. So I think whether it's NALIRIFOX or modified FOLFIRINOX,
right,
where we lower the doses of oxali and irinotecan, this make it probably manageable for older patients who have a good performance status. So I would go by the performance status at this point rather than just the number. The age.
What about the older, frail patient where, you're even questioning whether to give chemo, Mitesh? What's your thought? What is your likely approach?
Yeah, that's always a challenging decision. You could always start with single-agent gem to ease them in to see if they can even tolerate a single drug, and then escalate to a doublet. You could modify the schedule a little bit. Instead of 3 weeks on, 1 week off, you could use a every 2 week schedule and based on the data out there, it seems reasonably comparable.
All right, let's talk about PARP inhibitors.
Okay, so I saw that people were using olaparib, so this is the POLO study. The incidence is going to be low, less than 3%, and in some ethnic populations, much lower. These are germline events. If you look at somatic and HRD events, now you're going to add another 5%, but this study was limited to germline events. PFS was improved. OS wasn't, but that's because there was crossover. And olaparib is an agent you guys use for many other things, particularly ovarian cancer, so you're used to the toxicities, fatigue, myelosuppression, GI toxicities.
Incidentally, I'm just going to go back just to let I told the audience that in the myeloma session, they're going to hear something I think is amazing, and it's one of the things is about African American patients. I note this is a typical trial, 0.2%. What we're going to talk about this afternoon is a trial that had 20% African Americans. We're going to talk about some of the data they're about to present, just FYI. All right, please continue.
Okay. So something that might be upcoming, so a new treatment modality, tumor treating fields. So these are electrical fields that you could apply to particular areas. This has been approved in brain cancers and mesothelioma and also lung cancer now. So PANOVA-2 was a study in pancreas cancer where there was promising data with progression-free survival and disease control. Now there's a phase 3 study adding it on to gemcitabine nab-paclitaxel. Primary endpoints overall survival. Quite large trial, as you can see, and I think sometime next year we should have the results of this study. This is in locally advanced disease because this is a local treatment. So a new modality, and we'll see how it does.
And that's a great point you made, that it is localized disease. And you mentioned, we'll talk this afternoon, there was a trial in ovary that there's a press release saying was negative, and of course there, it's hard to kind of encompass the disease. Anthony, I'm curious, and actually I don't think it's actually approved in lung, but they had a positive trial just presented at ASCO. Actually, phase 3 trial, controversial because they had patients who didn't get typical first-line therapy, but they saw survival benefit, but it was in people who had IOs, and nobody knows what it means. They're not going to start using it in lung cancer, but it was just kind of interesting. Any thoughts about this, Anthony? It is a different strategy in a disease that we really, kind of run into the wall in general. It does, we'll talk with the ovary. You had more experience there. They have a lot of skin irritation from the electrodes. Any thoughts, Anthony, about this strategy?
It's certainly a novel strategy, and the hypothesized mechanism behind it is certainly complementary to what you would get with cytotoxic or IO therapy, right? So, I think there's more and more being learned about it. So I think it's definitely worth exploring more. It's just the trials have to be designed correctly for this. Because we'll talk about this in HCC, and that trial was very difficult to interpret.
Right, and also, even again, not life-threatening toxicity, but pretty nuisance toxicity that we've heard about in the skin, maybe more than, say, GBM, where it's just on the head. I also wanted to get your clinical take about what you're doing. We've had data out there with PARP and pancreatic, maybe not quite as exciting as what we've seen in, ovary and other situations. But I am curious, Mitesh, right now, how you're approaching it. If you know a patient, for example, has a germline mutation or even a somatic mutation, a BRCA, PALB2, let's say you know that before you even start treating them for metastatic disease, maybe have a family history, et cetera. When are you going to think about a PARP inhibitor, and which one and how?
Yeah, for those patients, we have a lot of data with platinum agents, actually. So instead of using gemabraxane, FOLFIRINOX, you do have agents that could affect those patients, but Gem-Cis might be a great regimen there. And once patients become a little beaten up with the cisplatin, my go-to PARP inhibitor, because of the robustness of the data, would be olaparib, although certainly there's data from other PARP inhibitors.
Anthony, any comments? That was the strategy looked at in the trial, sort of as a maintenance after chemo. Any situations where you might give it without chemo, a patient, say, with a BRCA mutation who you didn't want to give chemo to?
I think the limited data that's out there, that the single agent activity is potentially quite low. So at this point, no, I wouldn't.
What about and we'll talk a little bit about the adjuvant situation, but What about in the adjuvant situation? Patients had a resection of a pancreatic cancer and was found to have, let's say again, BRCA mutation, PALB2, germline, somatic. Maybe the patient's a doc and says, how about giving me a PARP inhibitor adjuvantly? Of course, there's a trial that's going to look at that, a very important trial. Any thoughts about that strategy, Mitesh, and would you give it to a patient who wanted it?
Yeah, without data, it always becomes a little bit challenging. Hopefully, over time, use of ctDNA as a way of just measuring residual, metastatic disease will allow you to use these agents even when you're thinking adjuvant, when they're really advanced patients.
All right, well, let's move on and talk about other new agents that hopefully might enrich the field a bit.
Okay, so we'll close out here. Biliary tract cancer obviously got the designation of being the lung cancer and GI cancers, but you can see that in pancreas cancer, it won't be so bad as things go along. About 10 to 15% of patients already have alterations. It's just that they're very low frequency individually, right? So NRG1 fusions, NTRK fusions, ROS fusions, BRAF mutations, MSI, they all add up to about 15% when you look at things. KRAS G12C, there's data, so you can even split the KRAS pie there a little bit. And now there's the KRAS G12D inhibitors that are in trials, so those are eagerly being awaited to see what kind of data they show.
Curious, would you use a RET? You have, you noted RET fusions, which of course we started seeing that with lung. But I have heard of cases outside of lung with RET where RET inhibitors have been used. Have you ever done that? Or are responses reported?
Yeah. And those have been reported both in trials and in patients who have these alterations treated with these FDA-approved agents.
So Anthony, over there on the left is something that totally fascinates me. I didn't realize that like Moderna originally was grilling along for cancer and then stopped and moved into COVID and now is back. And they've got these targeted vaccine, mRNA vaccines individualized to the patient. I see popping up in different cancers being studied. Any thoughts about that strategy? It sounds really interesting.
I mean, scientifically, it's a very exciting and potentially promising strategy. I think we don't really have sufficient data yet to see how well it's going to work, especially in a complex disease like pancreas. So I think we'll see over time. I don't know, Mitesh, if you have...
Yeah, there's been the trial out of Memorial Sloan Kettering that used this strategy, and preliminarily, at least, it's showing some activity. Yeah. They'll probably need to be combined with checkpoint inhibitors to get enough efficacy to get them across the finish line.
Yeah, we had Eileen O'Reilly on our webinar recently, and she was talking about it. I just like the fact that it's different. I mean, we're at such a standstill with the pancreatic. It's really a shame, and it's great to see at least something for the future. Let's move on now and talk about HCC. One of the interesting things about the AON data, I don't know, I always sort of visualize HCC as not being very common, because when I ask docs to present them, they don't have as many cases as some of the others. But maybe that's because they're dying. I'm not sure why, but there's a lot of HCC in this practice.
Well, two phenomena, right? This is one of the diseases that's continuing to rise in incidence, unlike many other cancers.
It's almost as common as pancreas.
Correct. Second is now it's being referred to the oncologists more. These patients used to be with surgeons and IRs before only, or on hospice. Now that the community knows that we have effective therapies, they're being referred to oncology, so we're seeing more numbers.
Really interesting. All right, let's talk about some of the new data, Anthony.
Great. So first, new data, exciting in the early stage HCC adjuvant data. So as you know, before I go into this, we had no adjuvant data. We had the STORM trial that looked at post-resection sorafenib versus placebo, which was negative. There were many attempts at looking at other adjuvant agents, all failed. So this IMbrave050 trial compared atezobev, the standard advanced regimen, to active surveillance post-resection. Now, one thing that's important about this trial, and unfortunately it's buried in the fine print at the bottom, but I bolded it and put it in red, it was limited to patients with high-risk features. So what does that mean? Either single tumor over 5 centimeters or more than 3 tumors, they had to have, or they had microvascular invasion on the pathology, or minor macrovascular invasion in the periphery, VP1 or VP2 on scans, or grade 3 and 4 pathology on on the tissue. So these were high-risk patients, and if you look at these resection or these criteria, they're not the typical patients that we resect in the U.S., okay? Because we don't usually resect multifocal disease in the U.S. or patients with VP1, VP2 invasion. So nonetheless, the trial was done successfully. It was a 1-to-1 randomization. The primary endpoint was recurrence-free survival, and crossover was permitted for the active surveillance patients to get atezobev if they recurred. So, and I'm showing this slide just to tell you that now we're looking at the data from the first IRF-assessed recurrence-free survival. This is the interim analysis data that we're going to be looking at for recurrence-free survival. Now, these are the baseline characteristics of these patients. You can see that more than 50% had a tumor more than 5 centimeters. The majority, like 91%, had one tumor. So despite the trial allowing multifocal disease, the majority had one tumor. And then 61% almost had microvascular invasion, which is a poor prognostic feature on tissue on the resection sample. And then VP1, VP2 was low, like 7.5%. So it's a high-risk population. Now, the trial allowed resection or ablation. So you'll see the small number of patients that had that had ablation at the bottom. The majority had a single tumor that was ablated. Now, here are the results. So you see at a median follow-up of 17.4 months that the median recurrence-free survival is not evaluable yet, but there is a hazard ratio of 0.72 with a positive p-value. And if you look at the 12-month recurrence-free survival, it's 78% with the atezobev adjuvant versus 65% with surveillance. What's challenging about these curves is how they come back together, right? So is this because of immaturity and short follow-up, potentially? And there's a lot of censoring. So longer follow-up would be helpful here. Now, people say, oh, we want to look for the overall survival. The challenge is more than 60% of the patients who recurred crossed over by design. So overall survival may not be positive either way. So that's going to be challenging. So we will see what happens. But as it stands today, the trial met its primary endpoint as a positive study. For the appropriate high-risk patient, I would use this adjuvant therapy.
Mitesh, are you actually doing this?
Trying to, because it's not FDA approved yet, we might have some challenges, but
right.
I think patients who are high risk especially, you should view them as future advanced patients.
But, I mean, these patients with current therapy have like a 50% cure rate? Is that going to stay, in general, is that plateau out?
So, well, the risk of recurrence, depending on the risk, is 50 to 65%. It's very high. One of the challenges here is, are we kicking the can down the road? Are we just delaying the recurrence rather than really improving the outcomes? And we don't know that yet.
And, I bring up the fact that they might be cured, too. So you're giving them a therapy, and they may already be cured.
Correct.
It's not like they have a 90%
Correct.
death rate here.
Absolutely. So as far as toxicity, that was really nothing new in the adjuvant setting that we had not seen with atezobev in advanced disease. You can see most commonly proteinuria, hypertension, things we are used to managing. Of course, now these are potentially cured or curable patients. So some of these things become an issue that you see arthralgias, pruritus, rash, they are inconvenient, they affect quality of life. And certainly the other things like bleeding and perforations are very rare, but nonetheless, this has to be given to the right patient and not to everyone. I'm going to switch gears now to advanced HCC. First, I wanted to start with the guidelines from Barcelona Clinic Liver Cancer Staging System, the BCLC, because there were updates to this that I want to highlight. First, for advanced stage HCC, which is stage C. By definition, these patients have portal vein invasion or extrahepatic spread. We now have a lot more options listed, atezobev, durva-tremi, or the TKIs if they're not IO candidates, and there are multiple second-line agents. The other big change is that now for intermediate patients with BCLC-B who have diffuse infiltrative or multilobar extension of their tumor, the recommendation now is for them to go straight to systemic therapy. These are patients who don't benefit from liver-directed therapy, and that's what was being done for them in the past. But now they're appropriate candidates for systemic therapy up front.
Could I ask you, Mitesh, to take a crack at taking this graphic and sort of translating into what you do in practice? I mean, I think one of the key questions that we all want to hear about is, when are you going to use systemic as opposed to intrahepatic? You have these interventional radiologists ready to go. You know, when do you say, hey, hold off, let me give the patient systemic therapy?
Yeah, I mean, as systemic therapies keep improving, it will make more and more sense to give these earlier and earlier, even if you combine the local regional therapies. So it'll flip the order in which you approach things. You probably want to give systemic therapy to as many intermediate patients as you can who might have infiltrative disease or high-risk features, and of course, all the advanced ones.
I remember thinking, Anthony, when the data first was presented, I think at the Asian ESMO meeting, which I never even heard about.
ESMO Asia, yeah.
Right, ESMO Asia, and all of a sudden the GI people are saying, oh, here's my first-line therapy, Atezo-Bev. So a real shift. The first thing I thought about is, the thing about all the oncologists who come up to me and go, these interventional radiologists are burning these people's livers, I can't treat them. And I was thinking, I wonder if that's going to change when we start getting better systemic therapy. Do you think you're observing that in your own center, and do you think it's happening in the community?
It is starting to change, slowly but surely. I think we just need to be a lot more, we need to do a lot more education about what constitutes failure of liver-directed therapy. Right? I mean, if you cannot sterilize and get a CR, a complete response, with 2 TACEs to 1 lesion, it's a TACE failure by definition. If you have worsening of liver function with TACE, that's a red herring. So you really need to switch to systemic therapy earlier. If you're developing different lesions over time, you don't want to fry the liver by keep chasing those, because the disease is telling you that it's multifocal. You want to go to systemic therapy. So those types of things have to be really disseminated more and more.
All right, Embrave 150.
Embrave 150, we're familiar with these data. Just a quick reminder, this is the trial for first-line advanced HCC, all Child-Pugh-A. It required an endoscopy within 6 months and treatment of varices per local standard. Patients were randomized 2-to-1 to Atezo-Bev versus sorafenib, and co-primary endpoints of OS and PFS. And the trial was positive for all endpoints, but these are the OS curves, median of 19 versus 13.4 months. And we have data here up to 18 months at 52% versus 40% OS rate at 18 months. PFS was improved, and response rate was at 30% with this combination. Now, Himalaya is the trial that evaluated one loading dose of tremelimumab, the CTLA-4 antibody, and combined with durvalumab, then with continuation of durvalumab as a single agent. This is known as the STRIDE regimen, compared to, the other arm was durvalumab, and the other arm was sorafenib. All Child-Pugh-A did not require endoscopy, but the trial excluded main portal vein thrombosis. Now, one thing to be careful about this trial, there were 2 comparisons, a superiority comparison of the STRIDE regimen versus sorafenib, and then a non-inferiority comparison of durva to sorafenib. It did not compare STRIDE versus durvalumab. There was no direct comparison built into the design. Again, a positive trial. You see a very nice separation of the curves. What's very unique about this study is the very long-term follow-up and that tail that Mitesh talked about. We here see 48-month OS rates of 25% versus 15%. Certainly, the medians were improved as well, 16 versus 13.8 months, with a hazard ratio of 0.78. So another positive study. No change in PFS with this regimen, the STRIDE, and the response rate was 20%. The other data that came out of this is the non-inferiority of durvalumab to sorafenib, and with longer follow-up, that has also been sustained as well. So when we look at long-term survivals in this trial, there was no difference in the characteristics of the long-term survivors versus the full data set. So there was not a unique subset of patients that constituted the long-term survivors. So we have two regimens that are approved. This is a summary slide of both of them side by side, not intended for cross-trial comparisons, but it's good to put these side by side because in clinical practice, we look at outcomes, but we also look at side effects. So if you look at grade 3 and higher treatment-related adverse events, they were a bit higher with atezo-bev, but they were mostly hypertension, proteinuria, and things like this. The steroid usage was slightly higher with stride, but certainly manageable. Bleeding events were higher in the atezo-bev study, but it did not exclude main portal vein thrombosis, which are the patients that bleed the most. So that's my snapshot on this.
All right, so let's talk about what this means. I often flash one, what would have happened if Himalaya came out first? You know, it always happens in oncology. When you get used to something and then something else comes along, it's different than, you know, the reverse. So, and how do you decide what situation are you using atezo-bev versus durva-tremi? One thing I just want to clarify, Mitesh, you know, when we think of durva-tremi, anti-CTLA-4 PD-1, you think of ipi-nivo, you think of problems. But you mentioned, or Anthony mentioned, it's only one dose of anti-CTLA-4, and I believe the need for steroids is much less than ipi-nivo, like half of it. So first of all, from the point of view of efficacy, can you separate these two? And what about tolerability?
Yeah, I mean, from an efficacy standpoint, the doublet with that single dose was superior, whereas durva wasn't, and you can see that reflected in the initial analyses and then...
Yeah, but I'm talking about atezo-bev versus durva-tremi. How do you decide?
Yeah, and that's a very difficult decision. Like you said, most people are already used to atezo-bev. Maybe those patients where you can't get the endoscopy done, or they have some other risk factors where you're not going to give the BEV, you might choose to use the stride regimen.
I'm curious, Anthony, whether you've actually used the stride regimen, how you find it tolerability-wise. How do you make the decision between the two? Do you present both options to patients, and what do you tell them?
I do present both options, and maybe I'll show my algorithm, and I'll come back to this slide. Oh, I thought I had the algorithm here.
Let me try to find it. Yeah, I think
it's after this, sorry.
Okay, great.
Here.
Yeah, cool.
So this is how I think about it. Patient walks into my office. These are all Child-Pugh-A for now. They have a clear IO contraindication. They're going to get a TKI. If not, atezo-bev continues to be the go-to regimen, right? Because it was first on the market, I think, and because of the endpoints being all superior. It's OS, PFS, response rate, etc. Now, if a patient has BEV contraindications, they're at a high bleeding risk, they're older, they had an MI a year ago, even though they would not have been excluded in the trial, why expose them to that risk, right? So I'm gravitating more towards stride anytime I have a BEV contraindication that I'm worried about. Now, if the patient is not a candidate for combination therapy, they're frail, they have VEGF contraindications, maybe they have compromised liver function, I'm using single agent PD-1 such as durva or sorafenib. Now, the AEs also are different, right? So you're going to see more BEV-related AEs with atezo-bev and more immune-related AEs, skin, GI, and hepatic with stride. So that's how I kind of approach it generally.
So a couple cool, great questions from the audience. Dr. Rudolph, hey, who's always in our chat room, wants to know, what do you do when you have a patient who has an overlap of cholangio and HCC, Anthony? How often do you see that, and what do you do?
Well, we do see, as we're biopsying more patients. So there's actually now currently a trial looking at gem-cis atezo-bev in mixed tumors. It's actually a cooperative group study.
Like mixed tumors is like an entity?
Yeah, it is an entity.
Really? Huh.
Yeah.
And that kind of ties into another question we got here on this one for a long time. Do you need to do a liver biopsy in all people with HCC? They have a classic clinical presentation, alpha-fetoprotein. What about NGS, though?
Yeah, and we don't have targeted therapies for the most part for HCC, but you might find some patients with FGFR2 fusions, IDH1 mutations. The only way you'll know is if you biopsy. You could, of course, do liquid biopsy as an alternate, but only way to know is to biopsy.
There are a couple trials now looking at beta-catenin mutations, which are in up to 30% of these patients. So
you can target those?
Yeah. There are new agents now that may preferentially work in that setting.
Interesting. Someone in the audience corrected me. I didn't realize that selpercatinib actually has a tumor agnostic indication for RET. Is that true? Okay. You're
That's right.
Okay, so I was wrong. So obviously, and then the other thing, this is what I heard. Biotin liquid ointment on the nails available in Target and Walmart. That's what I heard. Have you ever tried that for the nail changes for FGFR?
Yeah, I mean, all these other remedies are worth trying, but I think, there's not going to be formal evaluation to see which ones of these are going to make sense.
Correct.
All right, here we go. Tumor treating fields again.
Yeah, so this is a very small study done in HCC. You see the evaluable patients were only 21, and part of the challenge in this trial, it included 52% who were Child-Pugh 7 and 8. So they were coming off therapy before their first evaluation, and 22% had ECOG performance status of 2. They aimed to show a response rate of 20% with the tumor treating fields plus sorafenib. They got 9.5%. So the trial didn't meet its goal, but a lot of the patients, again, were challenged. It should have been studied probably in patients with better performance status, all Child-Pugh 8, to really understand the signal first. And again, the other challenge is having to keep this on your body for 18 hours a day. But I think there are new versions of these skin arrays that are coming out that are going to be easier potentially.
Yeah, that's what I'm hearing. Also a smaller battery pack, because the other one, I guess, was kind of heavy to carry around.
Correct.
So if it works, you can always try to minimize tolerability issues.
Yes. So switching quickly to second line, I have the summary table just to remind us all that all the second line data was post-sorafenib data. Okay, so regorafenib, cabozantinib, and ramucirumab versus placebo all studied post-sorafenib. The cabozantinib trial allowed up to 2 prior lines of therapy. That was unique about that study. Now, the nivo-ipi, which has accelerated approval, was also post-sorafenib. It did allow more than 1 prior lines as well, but it had the unique activity with a response rate of 32% and a median OS of almost 23 months. So that was uniquely active, but at the cost of immune-mediated events, as we mentioned earlier. And then there's still data for pembro single agent post-sorafenib from the Chinese keynote 394. So now we are extrapolating and using these agents in a random fashion post-IO, post-atezobev or post-durva-tremi, without much guidance. So there is some data emerging from real-world evidence that I'll cover very quickly. This is, again, a retrospective multi-center study looking at patients who got lenvatinib post-IO. You see 109 patients got it post any IO, and 39 patients got it post-atezo-bev. And you see that the responses didn't seem to matter. The response rate was the same, whether it was second line, whether it post-IO or post-atezo-bev. Now, these responses are quite high because they also used modified RECIST and physician assessment. In the Child-Pugh subgroup that was post-IO, which was 42%, there was also still activity with this agent as well. So the median OS post-atezobev with lenvatinib was 14 months. So limited data set, retrospective, but it tells you there is some activity of this agent, okay? It just doesn't tell us if it's better than others. This is another data set with real-world evidence looking at cabozantinib post-IO. Now, the issue here, 22% or 20% were Child-Pugh. The majority of these patients had a prior IO, either single agent or combination. But the majority here got it third line and beyond. So this is really refractory patient population. You still see a stability of disease in the 63% range, and 67% for Child-Pugh subset, and a median OS of 7.5 to 9 months if you're looking at overall versus Child-Pugh. So again, the agent does show activity that's within the range for Child-Pugh of what we saw with post-sorafenib in the pivotal trial. So the TKIs have activity based on real-world evidence. We just don't know how to best sequence them or not. For nivo-ipi post-atezobev, this is always a question. We really do not have data. And the trial that's been published is a very small trial from Hong Kong with 25 patients or so, with some activity. But I think we need more data in that space. Novel agents, should I cover that quickly? All right. So there are more efforts to target other checkpoints beyond PD-1 and CTLA-4. So there's an ongoing study with relatlimab, the LAG-3 antibody in HCC. This looking at nivo-bev, relatlimab versus nivo-bev. And that is based on the data from the Morpheus trial, a phase 3 study called Skyscraper or I Am Brave 152 with the TIGIT antibody, tiragolumab added to atezo-bev versus atezo-bev placebo. Now, other novel agents, I mentioned the beta-catenin mutations. This is the ASI compound E7386, which inhibits the Wnt beta-catenin pathway, which has downstream effects on angiogenesis and immunity. And this agent actually in phase 1 did show some activity, so it's currently in an expansion in HCC. And that is the other Tvardi compound that targets STAT3. Now, STAT3 is actually a very important mediator of inflammation, of carcinogenesis, and it plays a pivotal role in HCC, and it plays a role in immune resistance as well. So this STAT3 inhibitor is being evaluated as monotherapy in refractory disease in combination with pembro post-IO and in combination with atezo-bev in first line. So just wanted to give a flavor of the activity, and that's it.
So I'd like to close by telling you about a case that just got sent in from the audience. And when I look at all these statistics, I think about something like this. So Mitesh, let me read this to you. I have a 44-year-old woman with newly diagnosed cholangiocarcinoma I saw last week. I am starting her on gemcitabine next week. What should I tell her about survival in lieu of these new agents? She is super young, so wants to give her all the possible chances. Not that you can come up with an exciting answer, but I'm just kind of curious, how you think through your discussion with a young woman like this. Perhaps she has minor children, et cetera.
Yeah. Quoting median survival numbers can always have the caveat that there's a wide variation, especially with a very heterogeneous disease as was described. So somebody younger, that's especially more pertinent. They might do much better just because of their age and lack of comorbidities. And I'd be very curious what kind of genomic alterations this patient has. If they have an FGFR2 fusion, for example, they automatically have longer survival because of prognostic aspects. Might be as much as double the survival if they didn't have it.
Anthony, any thoughts about, again, what you say to a patient like that, and also some of the palliative issues that come up along the way with these diseases?
Yeah. As far as talking to the patients, I find that talking about survival rates at 1 year, 2 years, 3 years is actually better. It's more realistic to the patient. What is the chance of being alive in 2 years? And I also tell them, if you stay in good shape, if we're able to sequence multiple therapies, the likelihood is you may do better than the average, etc. It helps. It's still a terrible disease with limited survival. Sorry, the other half of your question was?
Some of the palliative issues you run into.
Oh, yes. So educating patients about, biliary obstructions, cholangitis, fevers, the anorexia that happens, the muscle wasting, and being proactive about these things in this disease is critical. So I spend a lot of time on that.
Mitesh, any complementary strategies, that you use? Exercise, meditation, psychotherapy, complementary treatments, acupuncture?
Yeah, across many cancers, exercise of some form seems to deliver some benefits, so there doesn't seem to be a downside there. And those other aspects that you mentioned might improve their quality of life, meditation, acupuncture, even if they don't lead to increased survival.
All right, well, we're going to take a lunch break. I want to thank both of you very much for joining us today.